Let's study about acromegaly and gigantism. Acromegaly is due to growth hormone hyposecretion that occurs in adult life after epiphyseal closure, and if there is excess of growth hormone before epiphysis closure, then it will result in gigantism. So, growth hormone hypersecretion, if it is before epiphyseal closure, then it is gigantism, and if it is after epiphyseal closure, then it will result in acromegaly. So, why there is growth hormone hypersecretion? It may be due to pituitary tumors, and these pituitary tumors may be somatotroph pituitary adenoma, or it can be mixed. In mixed, it will secrete both growth hormone as well as prolactin. So, growth hormone hypersecretion is due to pituitary tumors that are somatotroph pituitary adenoma, or they may be some adenomas which are mixed and secrete growth hormone as well as prolactin. Rare causes of excessive growth hormone secretion are pancreatic islet cells tumors, excessive secretion of growth hormone releasing hormone from hypothalamic lesions, bronchial carcinoid, and the most important one is small cell lung carcinoma. Clinical features of acromegaly: first is soft tissue changes. So, what are the soft tissue changes that are seen in acromegaly? There will be thickening of skin, increased skin tags, there will be acanthosis nigricans. So, acanthosis nigricans is also seen in growth hormone hypersecretion. Next is increased sweat and sebum, which will result in moist and oily skin. Next is enlargement of lips, nose, and tongue. There will be increased heel pad thickness. There will be visceral enlargement like thyroid, heart, and liver. There will be carpal tunnel syndrome, myopathy, sleep apnea, and Raynaud's phenomena that is also seen in sclerosis. What are the bone changes that are present in acromegaly are there will be large spade-like hands, there will be large feet, proganthism. Proganthism is protrusion of mandible. Next will be there will be prominent supraorbital ridges. Next is there will be large frontal sinuses. Next is there will be wide spacing teeth. Next, there will be arthropathy, there will be kyphosis, there will be osteoporosis. What are the metabolic effects? Metabolic effects is the person will have glucose intolerance and clinical, or we can say it as clinical diabetes mellitus. There can be some pressure effects that are same as seen in pituitary tumors, that is compression of the dura mater which will lead into headache, or there can be pressure effects of pressure to the optic chiasma, optic tracts, optic nerves, which will result in visual defects, or they can be compression to the cavernous sinus, which will result in third, fourth, and sixth nerve palsies. They can be cardiac effects, which will involve coronary heart disease, cardiomyopathy, hypertension, left ventricular hypertrophy. These cardiac effects is due to the increased risk of cardiac profile, that is, there will be decreased HDL and increased LDL. Others are there will be increased risk of colonic polyps. So, colonic polyps are also increased in growth hormone hypersecretion or acromegaly, and it may increase the risk of carcinoma. What are the investigations to diagnose acromegaly? We can clinically diagnose the acromegaly, or we can investigate if there is any pituitary tumor or elevated IGF-1 levels, or the growth hormone levels are measured during an oral glucose tolerance test. As we can see in metabolic effects that there is glucose intolerance, so we can do oral glucose tolerance test, and there will be failure of suppression or paradoxical rise of GH indicates acromegaly. Now, what is the treatment? Treatment is we can do the surgery. Surgery by transsphenoidal surgical removal of adenoma. Medical therapy may be the primary treatment with drugs that is indicated in the people which have no risk of visual impairment from the tumor, or having poor or are the poor candidates for surgery, those who decline surgery, or with tumors unlikely to be controlled by surgery, or who requires preservation of intact pituitary function. So medical therapy is given to the patients who are not having any visual impairment, that is no pressure effects, or who are the poor candidates for this surgery, or the tumor can't be controlled by surgery, or or we have to preserve the intact pituitary function, especially fertility. So we can't do surgery in these patients, so we will give medical therapy. Medical therapy involves bromocriptine or cabergoline, which are dopamine receptor agonists, which are useful in those with mildly elevated IGF-1. So if there is mild elevation of IGF-1, we will give dopamine agonist, bromocriptine and cabergoline. Octreotide and lanreotide, these are somatostatin analogs. As we know that somatostatin is antagonist of growth hormones, so we can give these drugs to inhibit. Somatostatin analogs are more effective than dopamine agonist and act on pituitary somatostatin receptors to produce inhibition of growth hormone and IGF-1. We can also give pegovisomant, which is GH receptor antagonist, which blocks peripheral IGF-1 action in almost all patients and is indicated in patients who are inadequately controlled with other modalities, or in patients experiencing clinically significant drug side effects. So we will give pegovisomant in those patients which are having side effects from other drugs, and it blocks the peripheral IGF-1 action. Tumor size should be monitored at intervals, as the therapy is directed at blocking peripheral growth hormone receptors and not at treating the pituitary tumors. We can give radiotherapy, external radiotherapy in patients not candidates for surgical therapy and in whom medical therapy fails. We can do radiosurgery with gamma knife or cyber knife. We will also give the treatment for diabetes, hypertension and hyperlipidemia. Thank you for watching. Like and subscribe.